Thank you for having me. My name is Galiatsatos. I'm an assistant professor at the Johns Hopkins School of Medicine in the Division of Pulmonary and Critical Care. I'm also the director of the Tobacco Treatment Clinic over at the Johns Hopkins Bayview Medical Center. So that means I see patients exclusively for their nicotine addiction and tobacco dependence. And every patient that I see, I usually, in my back of my mind, think immediately, all right, they smoke. They may be struggling with something called ambivalence, which means they want to quit, but they can't see themselves without quitting. So in the back of my mind, I'm thinking about how do I get this patient to ultimately be smoke-free. And the first immediate approach that I take is making sure that patient tells me everything they understand about smoking. Not so much the health ramifications. I think most people understand smoking is bad. But what I want them to tell me is, what role does smoking play in your life? When do you smoke? Why do you smoke? What brand do you smoke? Tell me how you smoke that cigarette. So really learning them as a person who smokes, for me, reignites this conversation between a healthcare professional and a patient, where the patient starts recognizing all the things that motivate and reinforce this behavior to smoking. And what really comes out of that conversation is the fact that smoking for them, it's more than just a behavior, and more than just a habit. It's a habit with an emotion, so it's more of a compulsion. Once you identify that, then I think you can start talking to the patient about how you'd like them to quit smoking. And in the back of my mind, that means implementing what I call a chronic disease model. So taking the time to get to know the person who smokes and not simply saying, just quit. I think taking that time, taking that investment is on par with the DNA of every healthcare professional. Treat tobacco dependence like any other disease and get to know the person with that disease. That's what our aim is. Once you have identified that, then you can begin to individualize a plan with them. So the individualization, this again takes time because you want to know the patient. So what I usually get to know the patients is, first things first is in the chronic disease model, is we're going to try to have touch points, right? So if you had high blood pressure, I'd ask you to check your blood pressure once a week with a blood pressure cuff. But for patients who smoke, I don't have a great equivalent to that, other than maybe a phone call or an email to check in on them. And this is where I tell a lot of healthcare professionals, if you don't have the resources, use the QUIT line. Tell your patient to call 1-800-QUIT-NOW and get on that program and use the QUIT number as a tool to helping your patients quit smoking. In my belief, it should never be the standalone. If a patient takes their own kind of a firm decision to say, no, I'm going to use the QUIT line and that's all, that's great. That's the patient's decision. But as a healthcare professional, I see the QUIT line as a great resource and a valuable teammate in a multidisciplinary way to get our patients to quit smoking. After that, we try to identify if medications are appropriate to help the patients quit smoking, and whether that medication is a frontline agent like varenicline or bupropion or a nicotine replacement therapy patch. I talk it out with the patient because we've talked about side effects, we've talked about risks and benefits, and we get to know if the patients have tried this in the past before. But most importantly, we always look at the cost effectiveness as well, so the patients understand how this will impact them more than just beyond health, but if there's any economic impacts and so forth. And again, a great resource for some of those products, especially the nicotine replacement therapies, would be the QUIT number. So for my patients who are in a tight budget, and we're not in this business to break banks, what I usually tell the patient is, again, chronic touch points, you'll get these medications for free. Call the QUIT number. And using them, and myself as a healthcare professional, we will help you become smoke-free. So all of this, getting to know the patients, in my opinion, helps reinforce the one strategy that we do consistently well, and that's a chronic disease management. So if we view tobacco dependence in the lens of chronic diseases, we suddenly will unearth all of our skills and will direct it towards a disease that is killing more of our Americans and more of our Baltimore City citizens than gun violence and opioids combined. This is where we should really take a firm stand to shift the responsibility solely off the patient and put it upon all of us to help them become smoke-free. And the last point that I'll bring up as well is when talking to your patients, no different than you would talk to them about any other disease, is recognize that coming at them in a non-judgmental way goes a long way to help our patients. So many of them feel judged and stigmatized because they smoke. And that will create a sense of friction between the healthcare professional and the patient. So what I usually always advise all my colleagues when we manage patients who smoke is to say, create a homophily, create a sense of unity with the patient. We're in this together, and at the same time, make sure you do identify yourself as the healthcare professional that will guide them through this. An easy way to remember that is I tell persons who I train with and work with is be pro-smoker, but anti-smoking. We can get them through this. We can help them quit as long as we get to know them and understand what smoking means to them. And then we can take whatever willpower they have and amplify it by touch points with the resources that I just mentioned, and even sometimes pharmacological agents to grow that willpower a little bit more.